and I would like to take this opportunity to welcome our visiting guest, Dr. Yoshihara. I said that correctly? And Ms. Cynthia from Northwell Health. Before I hand you over to Dr. Yoshihara, I would just like to give you a little background about him. He earned his medical degree from Nagoya City University Medical School in Japan, which is one of the top 10 medical schools in Japan. He went on to complete both his residency and orthopedic internship at the same university, becoming one of Japan's youngest board-certified spine surgeons. Before overseeing extensive research into regeneration of post-injury spinal cord at Drexel University College of Medicine in Philadelphia. His research helped Dr. Yoshihara to achieve his PhD from Nagoya City University Graduate School. He also completed many fellowships, and all of them focused around the spine. So much so, he is one of the most respected spine experts that we have. And in addition, he is the only double certified, board certified doctor, orthopedic surgeon, both here and in Japan. So there's so much more I can say about him, but not to take away from what he has to share with you here today, I will hand you over to Dr. Yoshihara.
Okay, thank you so much. So thank you so much for a nice introduction. As you see, so I grew up in Japan, so I'm not great at English, and I have a very strong accent. And also, I'm not a great speaker like you and him, so I'm sorry for that beginning. Okay, so in the US, I'm the attending surgeon for more than 10 years. 9 years at the SUNY downstate, and the last 1 year, I was at private practice, also Virginia. But for me, I grew up with Asian food, so not much there, so I decided to come back here. So now I'm working at Northwell. So I'm working at the Legal Park office, and I'm doing the spine surgery at the Long Island Jewish Forest Hills Hospital. Actually, I get this presentation notice last week, so I'm sorry, I'm not as prepared. So, but today I talk about low back pain and leg pain. So I explain a common low back disease. So source of low back pain, it can be visceral related, vessel related, spine area related, or psychologically related. Talking about the visceral related low back pain, it can come from pancreatitis, pancreatic cancer, cholecystitis, duodenal ulcer, colon cancer, uterine fibroid, endometriosis, ovarian cyst, even ureter stone can be like a low back pain. So this is an abdominal CAT scan of one guy. So first is the problem with this CT. So this guy has a ureter stone here. This is like a white spot. So actually this is me. So I had a very, very severe low back pain, and it was from the ureter stone. So at that time I was working at the downstate, so I went to downstate ER for 3 times. Also, vessel-related low back pain. Dissecting aneurysm of abdominal aorta also can similar to the low back pain. I have never had this kind of problem, but I had the pain coming from this dissecting aneurysm is very, very painful. So this one is similar to the low back pain too. And also, interestingly, singles shows like mimics the low back pain. So this is a picture of the back. So you see the rash here. So enough patients coming to the spine clinic because of these singles. So at least I had 4 patients when I was practicing in Japan coming to spine clinic and complain low back pain, and it was singles. So I have to check the skin too. And unfortunately, patients cannot see the back, so then they didn't notice. But I'm a spine surgeon. Of course, I don't mean to talk about the aforementioned sources of low back pain. Today, I talk about spine-related low back pain. Spinal sources of low back pain can be degeneration. Degeneration includes everything like aging changes. Also, muscle dysfunction can make low back pain. Inflammatory disease like rheumatoid arthritis, ankylosing spondylitis, tumor, primary tumor of the spine or metastasis to the spine from the breast cancer or prostate cancer, metastasis to the spine and can make low back pain. Trauma like sprain or fracture of a spine, and also the infection like pyogenic spondylitis also can make low back pain. So this is a picture of the fracture dislocation of the spine, and this is a compression fracture of the spine, and this is an infection of the spine. But most of the low back pain is coming from top to degeneration and muscle dysfunction. So common degenerative, like aging, low back pain, disease are all these three. One is lumbar disc herniation, which is most common in younger patients. Number two, lumbar spinal stenosis, which is most common in older patients. And today it's like more, not very young patients, maybe you can have spinal stenosis. Number three, lumbar spondylolisthesis. This one often indicated for surgical treatment. These are today's main topic. Starting with lumbar disc herniation, I believe you heard this kind of words. Lumbar disc herniation means nucleus pulposus comes out from the tear of annulus fibrosus. So this, hold on, I'm sorry. Yes. So maybe this is the spine bone. So this is the anatomy area of the spine bone called the vertebra. This is also the spine bone. So in between this, you see like this black narrow area. This is the disc. So disc is a cushion between each spine bone. So disc is also consists of two components. One is this blue one is the annulus fibrosus, and the nucleus pulposus is this one. So when the tear happens, the nucleus pulposus comes out. And then if it comes out and then pinching the yellow one, this is a spinal nerve. If pinching the spinal nerve, or the patient can have leg pain. Okay, so something happened. I'm sorry, I have to go this way. Okay. So then this yellow nerve is pinched, and then the pain is coming from mechanical stress from the disc herniation, and also inflammation happens, and both mechanical stress and inflammation cause pain. Symptoms of lumbar disc herniation can be low back pain, and also leg symptoms like leg pain, leg tingling or numbness, or sometimes patients have leg weakness. Usually leg weakness is doesn't happen. Even the patient has leg weakness, that is usually because of the pain. And very, very rarely the patients have the number one or number two dysfunction. We call it a coda equina syndrome. So the patient can't control the urination. This is because of the huge herniation and pinching all the spinal nerves. Okay, so sorry, please go ahead. Please. So then talking about the physical exam, like sensation of the motors of the legs of the patients, depending on which spinal nerve is compressed, the patient has a different type of the symptoms. For example, if the patient has a pinching of the number L4 nerve, the patient has the pain almost the knee and down to the medial of the lower leg. And Lumbar spine 5 is compressed. The patient usually have the sciatic pain and also has the pain down to the lateral side of the lower leg. And if the patient has the weakness of the muscles, if the lumbar spine 4 nerve root is compressed, then usually this muscle, front of the thigh called the quadriceps muscle gets weak, and then patient has a like kind of buckling of the knee and then going this way. And L4 or L5 nerve root compressed, then patient also has difficulty pulling up the ankle, so then drop foot. Sometimes this one also can happen. So to assess lumbar disc herniation, we need to have MRI. This is the MRI picture. This is a side view of the back. This is the back side, and this is the belly side. So you see this square one is a bone, and in between you see the narrow one, this is a disc. So looking at this area, you don't see this kind of big extrusion. This is a disc herniation. This is the area for the spinal nerve. So you can imagine this disc herniation is pinching the spinal nerve. This is called the axial view. So this is like a transverse cut of the spine. So this is like a disc area, and also the disc, this area is for the spinal nerve called the spine. So this is a disc herniation, and this red one is a spinal nerve. So this disc herniation is bumping of this side. So looking at the size of the spinal nerve, this red one, this is like a round. But looking at this one, this spinal nerve is squashed and also pinched by this disc herniation. So the patient can have leg pain too. Next one, please. So then, what is the treatment of lumbar disc herniation? Usually, time. Most of the patients gets better with time. But in the meantime, of course, the patient has pain, so we prescribe medication like pain medication. I think you guys know non-steroidal anti-inflammatory drugs like ibuprofen or Aleve or Morphine, that kind of medication. If the pain is very, very severe, so we sometimes give the narcotic medication, but I don't like narcotic medication. And disc herniation patients oftentimes get good recovery from the steroid 1 week pack called the steroid pack. This is like a 1 week pack with a taper dose. This one works very, very good for some patients. And also, those patients have some muscle spasm to the back, so we also prescribe muscle relaxer. So when the patient has very, very severe pain, we don't recommend physical therapy. But if the pain is going down to maybe 5 or 6 out of 10, that time I recommend physical therapy. So then most of the patients get better. But if it doesn't get better and the MRI shows a clear disc herniation, next step is an epidural steroid injection. This is a picture of the epidural steroid injection. So also this injection for some patients works good for a long time. And then if none of these doesn't work, unfortunately, final option is a surgery. That's my part. Okay, next please. So natural cause of lumbar disc herniation. More than 90% of the patients get better in 2 months. So usually herniation is absorbed by immune system. And also inflammation subsides with time. So only limited patients finally need surgical treatment. But you have to be patient for like weeks to like 6 weeks or 2 months. Next, please. So surgery. But please don't wait more than 2 or 3 months. So because if waiting too much, like 4 months, 5 months, surgery becomes difficult. The inflammation that disc herniation area can make adhesion. If adhesion is made, so to take out the disc herniation, so disc herniation is adhered to the membrane holding the spinal nerve and can make a tear too. So then it happens with a complication. And also, if the spinal nerve is compressed for a long time, so it is more likely those patients have residual tingling or numbness. Also, brain can remember the pain if it's compressed for a long time. And I know many people are afraid of the surgery, but disc herniation surgery is only 1 hour operation. Sometimes, like it's only 40 minutes. Also, going home same day and walking same day. So it's not like a terrible big surgery at all. Next, please. So surgery, this picture. So I usually this kind of small tube. This is like 2 centimeter, and also I do the endoscopic spine surgery too. So this is a skin incision. It's less than 2 centimeter. It's not a big incision at all, and going home the same day. Next, please. So let me explain one surgical case. This guy is 36 years old who had low back pain and right leg pain around the knee area. So he had this kind of symptoms for 2 months, getting worse, cannot walk 1 block, and he tried medications, physical therapy, chiropractic treatment, and steroid injection, and also steroid oral intake, but nothing worked. So he can't stand up straight, so he was walking like this way, and also he had some decreased sensation at the right knee area. So this is the MRI of this guy. So you see disc herniation here. So this is between lumbar spine 3 and 4. This is a transverse cut of the spine. So disc herniation is going this way. Actually, this like a bump is more on the this side. If this is the center, this is the left side. But actually, this is in this image the patient opposite right side. So spinal nerve is here and also here. So you see the difference here and here. So this spinal nerve, patient right side is pinched. Actually, this is me too. Next one, please. So I'm 53 years old. So then I had this surgery. So 17 years ago. So my surgery was very successful, so I had my surgeon took this kind of big piece of disc fragment. This is around 3 centimeter. For me, I could walk on the same day, and also I went back to work 3 days later. Okay. Next, please. So next, lumbar spinal stenosis, the second one. So etiology of lumbar spinal stenosis. It is most common spinal disease in the older patients. The prevalence of symptomatic lumbar spinal stenosis is 9.3% in the big study. So it's very common. The prevalence of the symptomatic lumbar spinal stenosis increase with aging. So this is an aging disease. So with more aging, more people get this disease. Also, interestingly, this is more common in female people. Next, please. And also, what's the pathophysiology? What's the mechanism of lumbar spinal stenosis? Spinal canal, which includes the spinal nerves, gets narrower and narrower with aging degeneration. So aging degeneration includes everything. Like in this picture, this is bulging, and also some excess bone comes up with aging, and also this black one is a thickening of the ligament called the ligamentum flavum. So then spinal nerve is pinched. Actually, spinal nerve here should be very big, but this is like a line. So symptom of the lumbar spinal stenosis, honestly almost the same as disc herniation. So low back pain, leg numbness or tingling. But also one thing interesting for lumbar spinal stenosis is neurologic intermittent claudication. This one is, this kind of patient start walking and then 3 minutes, 5 minutes, 10 minutes walk. Gradually feels very tight in the buttock area and also leg. And then finally, I can't walk because I feel leg is very heavy and also painful. And then patients sitting down for 5 to 10 minutes, then start standing again and also walking again. Patients can walk another 5, 10 minutes. So then also this one gets slowly worse. So then first, I could walk every 10 minutes, then slowly, gradually, 5 minutes, and then finally, I only can walk like 1 minute and then getting rest another 1 minute. Sometimes also can make like a pain issue for this kind of patients. Physical exam of the patients. Usually the patients are okay, so no weakness or no sensation problem. But interestingly, when the patient start walking and 5 minutes, 10 minutes, and then patients notice, my legs feels weak, and then my knees like a kind of buckling down, and also ankle gets like a, kind of a dropping. So, but this one gets better with like sitting down, rest, or laying down. And also one interesting sign for lumbar spinal stenosis patients is called shopping cart sign. So patients with lumbar spinal stenosis going to shopping center and using shopping cart, very easy to walk. And compared to walking without shopping cart, I can walk very easy with shopping cart. That's like a typical sign of the lumbar spinal stenosis. So MRI of lumbar spinal stenosis patients. Left side is a normal MRI, and the right side is lumbar spinal stenosis patients MRI. So as I explained, this is a bone disc like, and then this is the area for the spinal nerves. So this is wide here. But looking at this one, this is wide. This area gets very narrow. So this patient has a spinal stenosis this area. This is lumbar spine between 4 and 5. I also show the transverse cut of the low back of the spinal stenosis. So in this picture, spinal canal is this one. This is very big space. But looking at the spinal stenosis patient's MRI cut, can you see this kind of big circle? No. So only this line. So because of this kind of ligament thickening, disc bulging, some bone, excess bone, so this big place becomes this line. This is very severe spinal stenosis. Next, please. So treatment of the lumbar spinal stenosis also almost the same as lumbar disc herniation. So starting with a medication, a pain medication, physical therapy, epidural steroid injection, and if the patient cannot walk more than 3 blocks at one time, I recommend surgery. Because, also next one please, yes. But please, again, don't wait more than 2 or 3 months. Surgery becomes difficult because spinal canal gets so much narrow and for a long time and make an adhesion and can make a tear to decompress that area. And also more likely to have the regional tingling or numbness of the legs. And I also noticed the patient with severe lumbar spinal stenosis, they don't go outside and they don't walk, because they have a lot of pain, so they tend to stay at home. So if the patient stay at home most of the time, what is going to happen? So then those patients don't use their legs, and slowly, gradually, muscle strength of the legs and even the arms get weaker and weaker. So then 6 months, 1 year, or everything is like atrophied. So after doing surgery, long time, that kind of situation, doing surgery, to get back to the like a good strength, it takes a lot of time. And the surgery for lumbar spinal stenosis, if only decompression for the stenosis area, so it's not a big surgery. Okay, so it's only 1 hour surgery for one level stenosis. Some patients have several segment stenosis. If the 3-segment spinal stenosis, of course, takes more time and have to stay maybe 1 or 2 days. But most of the patients, for the only decompression surgery for the stenosis, goes home same day or 1 day after the surgery. So it's not a big surgery. Next, please. So this is an example of the decompression surgery for the lumbar spinal stenosis. Left side shows the spinal stenosis. You see this big round one is going this way. So the surgery itself is to remove this kind of tissue to give more space to the spinal canal. So after the surgery, this small area gets big like this. So this surgery is just decompression surgery, and again, so it's not a big surgery. Patients can go home same day or next day. Next, please. But lumbar spinal stenosis patients sometimes have a lot of arthritis changes to the spine. Those patients need decompression and also fusion surgery. So let me explain one patient with stenosis with a lot of arthritis. This patient is a 77 years old female, so not a young patient, and had low back pain and both leg pain. So difficult walking, I believe. I remember the patient couldn't walk more than 1 or 2 blocks. And even the patient had some pain when sleeping because it was very severe stenosis. And please, next. Of course, this patient, she tried everything, including medication, physical therapy, and injection, nothing worked. So this is the X-ray of this patient. So compared to this area and this area, you see, this area looks like a kind of, doesn't look bad. But looking at this one, you see a lot of messed up. This white means a lot of arthritis changes. And also looking at MRI, this X-ray of the side view, so this square one is bone. In between the disc space, looking at this area. So there is no space for the disc. So disc is almost like wearing out and no disc space. A lot of arthritis changes here. This is an MRI of this patient. Again, this is the spinal canal, where it is for the spinal nerves. So looking at this, not only one place, 1, 2, 3, 4, all spinal stenosis compared to this area. This is a transverse view, we call it axial view. Spinal canal, we can't see. So this is a very small spinal canal because of this ligamentum flavum thickening and also arthritis changes. So the patient diagnosis is a severe lumbar spinal stenosis at multiple levels, maybe 1, 2, 3, 4, and also a lot of arthritis changes, including disc degeneration and also bony spots. This is an X-ray before surgery and after surgery. Unfortunately, this patient also needs the fusion surgery, not only the decompression surgery. So again, this patient has a lumbar spinal stenosis and also severe arthritis change. So this patient needs the decompression for the spinal stenosis and also fusion surgery for the severe arthritis change to improve both leg pain and also low back pain. Next one, please. This is a side view of the surgery. You see a lot of this kind of fusion surgery with the instrumentation with the metals. Usually these are the titanium. I hope I don't have to do this kind of big surgery, but these patients are needed. So I talked about 3 common low back disease. One is lumbar disc herniation. Second one is lumbar spinal stenosis. Last one is spondylolisthesis. Spondylolisthesis means this is a bone and this is a bone. It's a slippage between each spine bone. Slippage. You see the slippage here. Next one, please. So this is almost the same picture. You can see the slippage, step off here. This is a spondylolisthesis. So this is the area for the spinal nerve. So then spinal canal, spinal nerve can be pinched by this kind of slippage and also step off of each spine bone. So this patient also has 2 problems. Spinal canal, spinal nerve compression, and also the instability of each spine segment. So 2 problems. So symptom of listhesis, honestly, again, it's almost the same. Low back pain, leg symptoms, leg pain, tingling, numbness, weakness, and also patients cannot walk long distance because of the stenosis there. So physical exam is the same. Usually patient doesn't have any weakness or a sensation problem when they are static. But by walking, leg pain comes up and also difficult to walk. This is an X-ray of spondylolisthesis, the step off and the slippage. So this is a lumbar spine 4 and this is a lumbar spine 5. So here you trace the back of each spine bone, spine vertebra. So it's very smooth line, but you see that this step off. This is a spondylolisthesis. This is between 4 and 5. Actually, this kind of spondylolisthesis is very common at lumbar spine between 4, 5, and also more common in the female patients. So usually this kind of step off starts around 50 years old or 60 years old. Those patients come to clinic, especially female patients. Next one, please. This is an MRI of the spondylolisthesis, the slippage. You see the slippage here, and also MRI shows the area for the spinal nerves. And you see, this is wide enough, but this is very narrow for the spinal nerve. So spondylolisthesis can make the spinal stenosis too. So treatment, actually, unfortunately, we spine surgeons don't have many options. The same treatment, starting with medications, physical therapy, epidural steroid injection, and finally surgery. So I talk about one case of the spondylolisthesis. This patient is also not young. I also do the surgery older than 80 years old. The oldest patients I did spine surgeries are 87 years old. So this patient is an 80 years old male who had low back pain and both leg pain and cannot walk long distance. This is the X-ray of this patient. This is the front back view. This is the side view. And also this is a flexion view like this way. And this is the extension view. I always take the X-ray with the flexion extension because I talked about the instability, not the stable spine segment. So spondylolisthesis has 2 problems. Lumbar spinal stenosis and also the instability of each spine segment. So looking at this neutral view and the flexion extension, you see here is not stable, slightly moving. So this is like a lumbar spine between 4, 5. Next, please. Yes. Again, so we need to get the MRI to assess the spinal nerve and also spinal stenosis. So this patient has lumbar spinal stenosis and degenerative lumbar spondylolisthesis, step off at lumbar spine L4-5 here. So very bad spinal stenosis here. Next one, please. So this patient again has two problems. One is spinal stenosis, narrow, and the other one is like instability. The spine segment has a step off and not stable. So I have to do two things. One is decompression for the stenosis. The other one is to stabilize that segment for the unstable spine segment. So decompression you can't see from the X-ray, but making stable, we use spine surgeon use metals like this. So then this patient has the decompression and fusion surgery at this 4-5 segment like this. Next one, please. So I finished those three common spinal diseases. But before I finish the presentation, I want to talk like a few more. Next one, please. So I believe psychologically related low back pain is very common. Even I'm a spine surgeon. So maybe autonomic nerve system becomes very unbalanced because of the psychological issue, and then back muscle gets tight. So when the back muscle gets tight, it can make very bad pain too. Because I believe enough people have the cramping of the calf here, right? So it's very painful. Where the pain is coming from? It's like a muscle spasm pain. Back muscle is also muscle. If back muscle gets very tight and making spasm, that pain can be very strong too. So that kind of studies are ongoing between low back pain and brain function using the functional MRI and SPECT. These are like a very detailed imaging studies. Next one, please. For example, again, honestly, this is an MRI of myself. So you see the bad degeneration. This area is good, right? This is a bone. This is a disc. This area is the disc is good, but I had a surgery here. I had a surgery here. So disc doesn't look good. Even this one, you see that this kind of step off, right? So bad aging, degeneration, arthritis changes. But looking at me, so then this is like a 16 or 17 years ago. If I get the MRI now, maybe getting much worse. But I don't have very clear or constant low back pain. And also I run the marathons, and also I play tennis very hard too. One more? Yes, please. Okay, so next one, please. Yes. Okay, so I believe it's like a psychological. And also last one, let me talk about the laser surgery. So many patients at Brooklyn, even in the Virginia, I also practiced in the Dallas before. Many people ask me about laser surgery. But, at the TV, so Laser Spine Institute made a lot of advice. But remember, so Laser Spine Institute is already bankrupt because they did a very bad job. And that's marketing. So please understand, laser surgery is not new at all. School, and so 1996, so it's 27 years ago. So we had laser surgery. So laser surgery is not new, okay? And also surgery is only indicated for the lumbar disc herniation. It's not indicated for the spinal stenosis or spondylolisthesis. So the mechanism of the laser surgery. So they put this kind of things into the disc space. And at the tip, there is a place for the laser. Okay, so then they coagulate inside the disc space part of the nucleus pulposus and making the pressure inside down, and hopefully this kind of disc herniation flow back inside because of the decreasing pressure. That's the mechanism of the laser surgery. And also, again, it's only indicated for the fresh lumbar disc herniation. So please be careful and not to be cheated by marketing. Okay, so next one, please. This is my contact information. So then I'm working at the Northwell Lego Park office. I hope you see this building. It's next to the Queens Boulevard. And also I do the surgery at the Long Island Jewish Forest Hills Hospital. Thank you. Next one, please. Thank you. Yes. Thank you so much. So thank you for listening with my bad accent and bad English. Any questions?
Please ask questions, don't be shy.
Yeah, I have.
Yes. Yes, sir. Yes.
So is there like a recommended exercise that you could recommend to us to, to protect the back from any, damage to the back that requires surgery down
Yeah.
the road? What exercise you would recommend?
Exercise, not the lifting like a heavyweight exercise. It's for the outside, muscles. I understand it looks good, but more important is the inside muscles, like a core muscle exercise. Okay, core muscle exercise is more like a yoga type exercise.
So what about like their age? What you recommend for them?
Even with aging, of course, long time yoga type exercise may be difficult, but very gentle yoga type exercise should be able to do that. Because fortunately, now, honestly, YouTube or Google shows much more information. If you Google maybe gentle, elderly people, yoga type, core muscle exercise, you can see a lot of YouTube videos. Some of them maybe like a 3 minutes or 5 minutes exercise. But if you don't do that, of course, you don't get like, I always noticed almost everybody going home get lazy, right? After going home, people don't do it. So I recommend many people at least maybe one time a week going to the physical therapy, and then people are kind of forced to do the physical therapy. And at the same time, then get the motivation doing the therapy. So at home, more motivation to do the home exercise too.
A question.
Yes, yes, sir.
Muscle relaxer.
Yes, sir.
Ideally, muscle to hurt is to prevent you from doing strenuous stuff.
Yeah.
So if you take the muscle relaxer,
Yes.
doesn't it overwrite the effect of the pain preventing you from exerting yourself?
I don't think so.
You know, okay,
Yes. But usually muscle relaxer, many people get sleepy. Yes, get sleepy, but you have to adjust the dose of the muscle relaxer. Usually muscle relaxer for the older patients, we don't recommend so much. Yeah.
Would you recommend, what machine or method would you recommend for
A machine for the home exercise.
decompression of the spine?
I know chiropractors like decompression, because I enough patient. I asked enough patients. Some patients gets better, and some patients don't get better. So my stance, as long as the patients and you feel good, that's good for you. That's my, some of the effect is maybe placebo effect, but as long as patients feel good, I think it's good. That's my stance. So decompression, if you feel good with that exercise, please continue it. But if you don't see any change or even getting worse, please stop it. That's all. Yeah. Yes.
Diet affect or make this type of sickness more fast? Diet?
There is no evidence diet affects this kind of disease, but at least if you gain a lot of weight, it's not good. More, degeneration, and because of the body weight and gravity stress, more degeneration happens, so not good.
So it's better to keep your weight.
Always better to keep the weight, yes.
The thing is, you already say it's psychological.
Yes.
Could it be stress can bring on muscle thing that can misdiagnose?
Yeah. So what's his question?
When I say stress,
Yeah.
can stress
Yeah.
induce sickness
Yeah.
be misdiagnosed as a spinal problem?
That one can happen because as I showed in the slides, I think, also I showed my MRI how many years ago? 17 years ago, right? Because I had enough, degeneration and disc degeneration and also arthritis changes. But looking at me, now I'm okay. So then, looking at the MRI instead of, oh, you have a lot of spinal disease. But for me, more important is the patient symptom.
Could you enlighten them about standing and sitting and posturing?
Could you,
So
yeah,
from
yeah,
Muslims,
yeah.
especially for prayer, they stand, go down, pray,
Yes,
go down,
yeah,
pray.
yeah.
Can this affect, especially for the elderly?
Maybe doing too much every day. Maybe doing too much every day, maybe, but I can't say so much because there is no study and there is no evidence, so I don't mean to say so much about it. Yeah.
Brother Shabi.
Yeah.
I noticed
Yeah.
on sciatica.
Yes. Yeah.
So this affecting a lot of people.
Yes. Yes.
Sciatica.
Yes.
So what are some of the causes of sciatica? What
Yes.
you could do to prevent it?
Yes.
If you could throw some light on that.
Yes.
Sciatica.
So sciatica can come from the pinched spinal nerve and also arthritis changes of the spine. Okay, so usually sciatica coming from the spinal nerve pinching, not only this area, but also shooting down to the lower leg. But if the sciatica type pain is coming from the arthritis change, usually doesn't go below the knee. So arthritis change includes disc degeneration. Disc is just wearing out, and also some bony spur, bony changes. That one can make the pain around here, and also this kind of area, sciatica type pain too.
So what are some of the things we could do to prevent this?
To prevent, I think we can't prevent. Everybody gets old, and finally everybody dies. So, so then everybody, spine is different from they are 20 years old. But if you do enough exercise, core muscle exercise, and also if you keep body weight, and also if you don't too much sports or too much lifting, I think you don't get too much arthritis changes. But even again, so I told you, even enough arthritis changes, oftentimes no low back pain, and low back pain can be managed.
Right. So sitting for too long
Yeah.
can cause this also, right?
Yes, of course, standing too long, of course, in the meantime, disc gets the pressure, and slowly, disc gets degeneration.
Another question.
Yes.
You find sometimes some people after they have a good night rest,
Yeah.
and they wake up,
Yeah.
they get back pain.
Yes,
Right?
yes.
So is there like a special mattress that they should use that you would recommend?
I always also get that kind of question frequently. But that one, honestly, as I answered to his question, so not everybody is the same answer. Some people like a hard mattress, and some people like a slightly more soft mattress. So you try and you choose one which is good for you.
One more question.
Yes.
What about sleeping posture? Like how people sleep?
Yeah.
Like some sleep on the side, sleep on the back. Which way you think is better to prevent or to help keep away lower back pain?
Usually, of course, sleeping on the back, like a supine position, is probably very natural. Sleeping on the side, but there is no study and no evidence. Side position makes the spine worse. But I also sleep on the side, and also I sleep on the belly a lot of time. So maybe okay. Yeah.
So our religion recommend that we sleep on the right side. So we put
Yes.
sleep on the right side.
So then that one I have answer. Probably it's not great. You always sleep on the right side. Better to go half and half. Sometimes left side. Otherwise, the one side muscle gets exhausted and can get like spasm pain. Change, yes. Physical what? Yes, physical therapy. Usually, medication on the physical therapy first and trying the 6 weeks. So after that, it doesn't work, we go to the next step. Usually the MRI, and also based on the MRI result, we order epidural steroid injection. Are you okay with that? Okay, good, yes. Any questions? Okay, good, yes. Oh, thanks so much. I'm sorry, this one finally didn't work. So, yes, thanks so much, yes. Yes, okay, thanks so much. Yes. Yes. Ah, yes. Yes. So you did a physical therapy and didn't work? Yeah. 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 So then, do you also do the home exercise too, or not much home exercise? Yes. So if you still have back pain, maybe. Huh? So,
So she has to take painkiller.
painkiller. Yeah. But if you have that kind of, you know, so therapy and also pain medication doesn't work, you know. Yeah. Maybe next step, you know, we get more imaging studies and also injection. Yes. Yeah.
All right, so
It's-
one more. Have you heard about cupping?
Huh?
Cupping? Cupping.
Bloodletting, like we cut the back and put a suction cup on it and let blood flow. Bloodletting.
I understand. You know, a lot of cups on the back, right? That one for the muscles. Doing that one makes like a blood flow to the muscles better, and muscle spasm gets less. It's the same for the acupuncture too. Acupuncture stimulates some autonomic nerve and also then makes the flow of the blood more in the muscles, and the muscle spasm can go down.
So you recommend it also?
As long as the patient feel good, I recommend. Yes.
All right, one last question, please. I know everybody's getting hungry. Any other questions? One.
Yeah. So what did you say? Okay.
Sorry?
Yeah.
About 25 years back.
25 years back. Okay.
At that time, I took the, they did the MRI, just saying there is some crack in my
Yeah.
disc, so
Yeah.
that fluid is coming and
Yeah.
while it's causing
Yeah.
pressure, I'm getting pain.
Yeah.
They give me
Yeah.
physical therapy.
Yeah.
Usually I avoid medication like painkiller, but
Yes.
sometimes I took it. What I did, I usually every 15, 20 minutes, I work in the computer.
Yeah.
So I work on maybe 5 minutes.
Yes. Yes. Yes.
That way I continue, but there is pain sometimes.
Yeah.
So then after 25 years, I went to the family.
Yeah.
So I changed my job. So that job I need to sit and be.
Yeah.
But maybe it should work, but I think like
Yeah.
as better.
Sorry, I can't hear now. So because it's so then what is the question?
I was cutting something. Then I
Yeah, you feel the pain more now.
after 2 days I feel that pain.
Yeah.
Still I feel. So I went to the orthopedic doctor. He suggested that I do the MRI.
Yeah. 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 Yeah.
When he's saying all this, so you just do the what's called physical therapy.
Yeah.
So my question is, why do you do this type of thing?
Why?
Why this pain again? What is the possibility there? Why is pain is coming? Pain is coming back.
Of course, you might have some muscle spasm again, and also small accelerated degeneration of the disc, or some, arthritis, advanced arthritis change can make pain. So I'm not surprised.
So I try and take the what's called the physical therapy, and I go back.
Yeah. So then, again, so then you do medication therapy and it didn't work. So then we go to the next step. So you didn't get any injections yet, right?
No, I didn't. Yes, I'm still that good.
Yeah.
Take the injection, but I don't want.
Okay. Yeah. Yeah.
Because it was not so severe, I can tolerate. So that's why I refuse to take that injection, steroid injection.
Yeah.
But I was better. I can tolerate everything.
Yeah, as long as you can tolerate the pain, you don't need an injection. But you are not happy with the pain, I recommend you get the injection. It's a very quick procedure too. Because I also had an injection 3 or 4 times in my life, myself. Yes. Okay. Yes. Okay. Thanks.
Oh, we can give that inshallah. Yeah, we can give that inshallah. Assalamu alaikum. Thank you very much. I would like to thank Dr. Hiro for his presentation.